Bismillahirrahmanirrahim. Quote of the day. Sometimes it takes a good fall to really know where you stand. Assalamu alaikum. Today the topic of my presentation is diphtheria, which is one of communicable disease under kind supervision of Professor Dr. Saira Afzal. Learning outline of my presentation is Introduction to Diphtheria, Epidemiological Triad, Chain of Transmission, Clinical Types, Level of Prevention, and at the end, recent advances. By the end of this presentation, participants will be able to describe about diphtheria, mode of prevention, treatment, recent updates, and MCQ session at the end. Introduction. Diphtheria is a bacterial infection caused by Corynebacterium diphtheriae, transmitted from person to person through close physical and respiratory contact. It can cause infection of the respiratory tract and involve throat, nose, larynx, local production of a false membrane with the release of exotoxin, which may lead to breathing difficulties and death. It is prevalent. The prevalence of diphtheria is almost throughout the world, occurs in a temperate zone. Epidemics are usually local and not widespread. In countries where effective primary immunization practice, it has become rare. Now come the epidemiological triad. First we discuss agent. Corynebacterium diphtheria or Klebsiella bacillus. It is a gram-positive club-shaped comparing Chinese letter L and V. There are 4 types of Corynebacterium diphtheria: gravis, mitis, intermedius, and minimus. Children mostly affected 1 to 5 years of age. Both sexes are involved. Low socioeconomic status are more prone to disease. Infants are immune till 6 months of age because of maternal antibodies. Most occur during winter and autumn, and the overcrowding is one of the environmental contributing factor. Now comes the chain of a transmission. The reservoir of this disease is infected person, may be case or a carrier. Both are the reservoir. And the source of infection is nasopharyngeal secretion discharged from skin lesion, contaminated fomites, and infected dust. There are 2 modes of transmission, direct and indirect. In direct transmission, the disease is spread by infected cutaneous lesion, droplet infection, and in the indirect mode of transmission, fomite-borne is the source of transmitting disease. And the portal of entry of this disease is mainly the respiratory route. A non-respiratory route is also involved, like cuts, wounds, ulcer, umbilicus in the newborn. The period of communicability of this disease is 14 to 28 days from the onset of disease. Carriers may have much longer time. Incubation period of the diphtheria is 2 to 6 days. Pathogenesis. Bacteria multiply in throat and release powerful exotoxin, which is responsible for the formation of grayish or yellow membrane all over the tonsils, pharynx, and larynx with well-defined edges and can't be wiped away. Marked congestion, edema, and local tissue destruction, enlargement of regional lymph nodes, sign and symptom of the toxemia. These are the diagrammatic representation of the diphtheria, which involve the back of the throat, whitish membrane. Heart, kidney, liver, adrenals, and peripheral nerves are the remote area which are affected by the diphtheria toxin. Diphtheria antitoxin may neutralize the circulating toxin, but ineffective once cell penetration has occurred. Now comes the clinical types of diphtheria. Almost there are four clinical types of diphtheria. First one is the pharyngeal diphtheria. Early manifestation are mild sore throat, fever, and malaise. There is the membrane formation at the back of the tongue and the voice showing the stridor. And there is the dysphagia, difficulty in swallowing, in large cervical lymph nodes, producing a bull neck appearance, and the patient give the toxic lobe. Laryngeal diphtheria, usually associated with pharyngeal diphtheria, may be primary or without membrane formation. Voice may be hoarseness, cough, stridor, and lessness, and the cyanosis. Death usually occur due to suffocation. In the nasal diphtheria, chronic serous or seropurulent discharge, crusty exudate around the nose, foul odor, white membrane form on the nasal membrane. And the last type is cutaneous diphtheria, also known as desert sore, chronic tropical ulcer, which show a punched out lesion and it present on anywhere in the body. And this type of the diphtheria is mostly uncommon. There are also some other types like ocular diphtheria, vaginal diphtheria, but these are the rare types. Complication of this disease: respiratory failure, occlusion of airway by a membrane. Acute toxic myocarditis can lead to chronic heart failure, arrhythmias, and sudden death. Neurological, in which palatal palsy, ocular palsy, and polyneuritis, and also renal complications are also due to the diphtheria. Now comes the level of prevention. First, we discuss the primary prevention. Primary prevention of disease by ensuring high population immunity through the immunization. Then comes the specific protection, and the specific protection there is involvement of the immunization, and the disease has a specific immunization. The toxide is the diphtheria toxide is grown in liquid medium from toxigenic Corynebacterium diphtheria, available in combination with pertussis and tetanus vaccine, give clinical efficacy of almost 97%. Allergy to toxide or any component of a vaccine is a contraindicated for administration. Local reaction like erythema is common, should be stored at 2 to 8 degrees Celsius. Frozen vaccine should never be administered. Routine diphtheria, tetanus, and a cellular pertussis primary vaccination schedule. The primary dose is given at the age of 2 months, and the next dose is given at the age of 4 months, and then there is 2 months, 4 months, and 6 months, and there is the interval of 4 weeks between these doses, and the fourth dose is given at the 15 to 18 months of age. And diphtheria, tetanus toxide, and acellular pertussis vaccine is a vaccine of choice for children almost 6 weeks through 6 years of age. If child have valid contraindicated to pertussis vaccine, then pediatric diphtheria, tetanus should be used to complete the vaccination series. If the 4 doses of diphtheria, tetanus, pertussis, or diphtheria, tetanus, acellular pertussis are administered before the 4th birthday, a booster 5th dose is recommended at 4 to 6 years of age. These are the ages when these vaccines are given. DTAP. 4 to 6 years of age before entering school. DT, acellular pertussis, 11 to 12 years of age. It is a booster immunization given at age 11. Every 10 years, 3 after tetanus and diphtheria, it protects adults. People of all ages need diphtheria vaccine. DT, acellular pertussis given for the young children. Tetanus, diphtheria is several pertussis for a young children, and tetanus and diphtheria given the young people and the old people. This is the vaccination schedule which is followed in the Pakistan, and diphtheria, tetanus and pertussis are given in the pentavalent form of vaccine. Also hepatitis B and Haemophilus influenza are also given at the 6 weeks, 10 weeks and 14 weeks. Then comes the secondary prevention. Secondary prevention of spread by the rapid investigation of close contacts to ensure their proper treatment and the diagnosis of this disease, mainly clinical. Simple throat smear should be examined. If diphtheria-like organism, culture should be obtained. Administration of antitoxin without waiting culture report. Now we discuss the Schick test. Immunity to diphtheria can be determined by a Schick test, useful for detecting person at high risk, such as physicians, nurses, and hospital staff. Intradermal test depends upon fact that toxin exert local destructive or irritating actions on tissues. 0.2 ml of Schick test toxin is injected into the skin of forearm as test, while 0.2 ml of inactivated toxin is injected on another arm as a control. How we interpret the results of a Schick test. If the reaction is positive reaction, comes in the case of circumscribed area of a redness up to 3 centimeter or more in diameter within 24 to 36 hours, and maximum by 4th to 7th day on test arm, and control arm has no change. Susceptible, the person is susceptible to diphtheria. And if there is a negative reaction, then both arms are without reaction, person is immune. And if the reaction is pseudo positive, then the red flush appears on both arms but fades within 4 days, allergic type of reaction. And in the combined reaction, true arm show true positive and control arm show a pseudo positive result. So the person is susceptible to diphtheria. Control and the treatment of a disease, early detection of cases and carrier, isolation and the treatment. Antibiotic not useful in acute infection, antitoxin a must and primary concern. Antitoxin obtained from a horse serum in the mild form 20,000 to 40,000 unit is recommended. In the moderate form 40,000 to 60,000 unit, and in the severe form 80,000 to 1 lakh unit is recommended. Commonly used antibiotics are penicillin, parenteral, and oral erythromycin. 250 mg drug is used for the treatment. How we control the patient by notify the higher authorities, and the isolation imposed unless 2 consecutive culture from the throat and 2 from the nose 24 hours apart fail to show virulent diphtheria bacilli. Diphtheria antitoxin should be given without delay intramuscular after given 0.2 ml subcutaneous as a test dose. Benzyl penicillin 2.5 lakh units every 6 hourly, or erythromycin 250 mg every 6 hourly for 5 to 6 days. And for the carriers, there is the recommendation of erythromycin 250 mg every 6 hours for 10 days. What's the recommendation for the contact of for the contacts with the diphtheria patient? If primary immunization or booster within previous 2 years, no further action is required. If primary immunization or booster dose of diphtheria or tetanus more than 2 years, then only booster dose is required. And for the non-immunized, close contact should receive prophylactic penicillin or erythromycin with 1,000 to 2,000 unit of diphtheria antitoxin and actively immunize against diphtheria. Contacts should be examined daily for 7 days for any evidence of diphtheria. Active immunization with diphtheria of all infants with subsequent booster dose every 10 years thereafter. This is the recommendation for the community. Now comes the institutional control. In case of diphtheria breakout in close community like boarding houses, orphanages, juvenile jails, schools and hospitals, the whole community should be actively and passively immunized with the defined antitoxin in 1 arm, 1000 to 150 units for an adult and 750 to 1000 units for children, intramuscular and zero point 0.5 cc of alum precipitated toxide in the opposite arm subcutaneous at the earliest opportunity. The antitoxin provides temporary protection lasting about 2 to 3 weeks. And after 2 weeks, a second dose of zero point 0.5 cc of alum precipitated toxide should be given. After this, take throat swab of the entire population and segregate all throat swab positive for 15 days because this is the time when passive immunity, which lasts only for 15 days, starts fade away and active immunity starts developing. After this period of 15 days of segregation, the active immunity will rise sufficiently to protect the inoculated person from the risk of infection. Then comes the tertiary prevention. Tertiary prevention of complication and deaths by early diagnosis and proper management. Time for the recent updates. What are the WHO recommendation for the surveillance standard of the diphtheria? Primary prevention of a disease by ensuring high population immunity through immunization. Secondary prevention of spread by the rapid investigation of close contact to ensure their proper treatment. And tertiary prevention of complication and deaths by early diagnosis and proper treatment. Surveillance data can be used to monitor level of coverage, target almost 90% and a disease as a measure of the impact of control program. There are some clinic case definition given by the WHO. Clinical description: an illness characterized by laryngitis or pharyngitis or tonsillitis and an adherent membrane of the tonsil, pharynx or the nose. And the laboratory criteria for diagnosis: isolation of Corynebacterium diphtheriae from a clinical specimen or four-fold or greater rise in serum antibody, but only if both serum samples were obtained before the administration of diphtheria toxide or antitoxin. This is the epidemiological update on the situation of the diphtheria in the state of America in 2021 between epidemiological week 1 and epidemiological week 42. 4 countries reported confirmed cases of diphtheria: Brazil, Colombia, Haiti, and the Dominican Republic with 18 cases, including 12 deaths. And what is this is one of the article related to the what is the true burden of diphtheria, tetanus, pertussis, and poliovirus in children aged 3 to 18 years in Asia. The true burden of diphtheria, pertussis, and tetanus in children aged 3 to 18 years in Asia is unknown because of weak or absent nationwide surveillance system. The available evidence highlight the inadequacies in immunity, either by gaps in a recommendation or suboptimal booster coverage, supporting the public health need for booster vaccination in this population. Now it's time for the MCQs. XYZ patient admitted in hospital with the suspicion of diphtheria and proper isolation is also done, but the incubation period of a disease passed and there is a chance of spread for close contact. What is the recommendation of immunization for close contacts? If primary immunization or booster within 2 years, no further action. If primary immunization or booster within 3 years, no further action. If primary immunization or booster within 4 years, no further action. If primary immunization or booster within 5 years, no further action.
Alpha.
A. Alpha.
Alpha A is the correct option. XYZ patient presented in ENT OPD with complaint of fever, sore throat and pain on swallowing. After examine, doctor confirmed the diagnosis of diphtheria. The isolation period recommended for this patient is still complete. Blood picture becomes normal. Two consecutive negative throat and nasal swab cultures, negative chest radiographs, and after completion of antibiotic course.
B.
B is the correct answer. Two consecutive negative throat and nasal swab cultures. A person underwent Schick test and throat culture for diphtheria. It was believed that he is Schick negative, but throat culture is the positive. So he is a patient, carrier, immune person, or a susceptible.
C.
A.
A is the right answer, patient, because a throat culture is positive. 8-year-old boy presented in OPD with complaint of fever, sore throat, and difficulty in swallowing. On examination, there is a membrane formation at back of throat and enlarged cervical node produced a bull neck appearance, which is the type of diphtheria, pharyngeal diphtheria, laryngeal diphtheria, nasal diphtheria, or a cutaneous diphtheria.
A.
Alpha.
Pharyngeal diphtheria.
A, pharyngeal diphtheria is right one. 10-year-old boy was tested for diphtheria. His throat swab was taken and Schick test was performed. Final result were that his throat culture was negative while his Schick test was strongly positive. On the basis of these results, he is case of diphtheria, immune to diphtheria, carrier to diphtheria, or susceptible to diphtheria.
C.
Alpha.
D is the right option, susceptible to diphtheria because his throat culture was negative, his Schick test was strongly positive. XYZ patient presented in dermatology OPD with chronic tropical ulcer. On examining, the ulcer is punched out in characteristic on the arm of the patient, which is the type of diphtheria according to statement. A pharyngeal diphtheria, laryngeal diphtheria, cutaneous diphtheria, nasal diphtheria.
C.
C.
C is the right
C.
one, cutaneous diphtheria. Patient is admitted in hospital with the diagnosis of diphtheria. Patient facing the problem of restlessness and difficulty in breathing. On 14th day of admission, patient was expired. Which type of diphtheria is fatal? Pharyngeal diphtheria, laryngeal diphtheria, cutaneous diphtheria, or nasal diphtheria?
Beta laryngeal diphtheria.
E, laryngeal diphtheria is correct one. Diphtheria is bacterial infection caused by Corynebacterium diphtheria transmitted from person to person. Which of the following age group is mostly affected by diphtheria? 1 to 5 years of age, less than 6 months of age, greater than 65 years, and women of reproductive age.
Beta.
A. 1.
A, 1 to 5
Alpha.
years of age. Diphtheria vaccine consists of diphtheria toxoid available in combination with pertussis and tetanus vaccine. Which of the following is not true about vaccine administration? People of all ages do not need diphtheria vaccine. It is a vaccine of choice for children 6 weeks through 6 years of age only. Booster uh, tetanus, diphtheria, cellular pertussis is given at the age of 11 years. In adult, booster dose is given every 10 years. Not true. A. People of all ages do not need diphtheria vaccine. There are multiple combinations of vaccine which are used to secure the child from three diseases like pertussis, tetanus, and diphtheria. Which combination is used in infant age group? A. EDAP, DTP, DT, DP, APT, or AT?
Alpha.
A.
A is the right answer. This is the key of my MCQ, and thank you.